Welcome viewers to KK Agrawal Med Talk. Today it's episode 491. So the show is coming towards one of the very important milestone, that is 500. In collaboration with IJCP, Heart Care Foundation of India and USB. I think last 2 years this show has made a great viewership, and there is a lot of scientific data diffusion across globe. Millions of viewers are seeing our videos and conversations with the experts. So today we are going to focus upon very important topic, that is antibiotics, the WHO essential drugs, and what are the important access group of antibiotics, and predominantly with reference to doxycycline. So whenever the antibiotic word comes, it is very, very important is that we talk about statins reducing the mortality, we talk about aspirin reducing mortality, now we are talking about SGLT2 inhibitors reducing mortality, but the antibiotics, they reduce mortality to much greater extent, especially in country like India. And a great intensivist only can talk about antibiotics. So I welcome Dr. Yash Zaveri, who is the head of critical care. Welcome, sir.
Thank you. Thank you, Dr.
Yeah, he is the head of critical care as well as emergency medicine at Regency Hospital, Lucknow. He has got a vast experience in the managing all kinds of ICU patients. And very important, his contribution towards the education is he is vice president Society of Neurocritical Care, and another important forum called as Sepsis Forum. He is a convener for Indian Sepsis Forum. So welcome, sir.
Thank you, Dr. Mahesh.
Yeah.
Thanks for the kind words, and I'm thankful to IJCP and the group for inviting me to the esteemed panel.
So I think today we are going to talk about WHO essential drug. Now, World Health Organization is a very, very important body, and it lists some of the drugs as essential drugs. So can you tell about the viewers about what do you mean by these essential drugs?
See, WHO, looking at the public health aspect, has listed a comprehensive list of drugs which are called essential drugs. The list is based on healthcare needs of the population, majority of the population. This is like a socialist approach, doing good for the maximum number of patients. It might not have very high end of drugs, but at the same time, it will have all life saving drugs. The list has been first formulated in 1977, and then it has been regularly updated. The basis of formulation of this list is to take into account high quality of drugs, competition, research on these commonly used life-saving drugs, as well as availability in every nook and corner of the world. These lists, the drugs in this list will come as a life-saving drugs for majority of these diseases. Majority of these agents are in the category of anti-infective category, including anti-malarial, some antibiotic, anti-leprosy, anti-tubercular. Though the Western disease profile might be a little different, but if we look at humanity at large worldwide, the infective disease burden from these four categories of disease are still large. So the essential component of this list will be contributed by these agents. Taking lead from this WHO essential drug list, every country also formulate its list based on the requirement, the disease profile in those geographical areas, and there are some modifications from the WHO list. The list categorizes drugs into various formulations, oral, syrup, injection, as well as it gives a rough guideline that this drug should be available at primary healthcare, secondary healthcare, or tertiary, or at all levels. This list should always be a part of your checklist in each of the hospital, because what happens, many of the newer hospitals, government as well as private, many of the times they don't have many of these basic drugs. So I think each one of us should be aware of this list, and we should try to have this in our formulary also.
I think very important point you have made, that the WHO has given a guidance about what kind of drugs should be available with hospitals, or what kind of drug I think each and every doctor should be having. And these are the essential drug, as you have mentioned, that for each and every doctor who is practicing, these drugs are very, very critical. And in the Indian settings, as you have mentioned, right, that in the Indian setting, certain drugs might be 10, 15% drugs might be slightly different, but otherwise 90% of the drugs are essential, which are same in the list of WHO. The another important point for today's discussion is that there is something called as access group of antibiotics, because the antibiotics should not be used in each and every antibiotic at each and every place. So, what do you want to tell about this access group of antibiotics?
Yeah. As you rightly pointed out, antimicrobial resistance is a big issue. This is a major roadblock to providers of good healthcare, and most of the achievements which we have achieved with antimicrobials have been undone. It might be in cases of infectious disease, it might be case of critical illness, trauma. So antimicrobial resistance is a big issue worldwide, not only in India, and not only for community acquired infections alone, also for hospital acquired infections. So looking at this antimicrobial resistance, WHO gave this classification which we called as aware classification in 2019. The aim of this classification was to mitigate antimicrobial resistance and to give a rough framework for countries and the global stewards to act upon. They classified the drugs, the antibiotics, into three categories: access, watch, and reserve. So access will have an easy access. Watch, you have to be very, very careful while you are using such drugs, and you should be justified doubly while you use these drugs. Whereas reserve, as the name suggests, these drugs should be reserved and should be used as last resort based on your cultural sensitivity patterns in your hospital. Going on to the question, the access group of antibiotics. It includes antibiotics, a wide range of antimicrobials, about 48 antibiotics, which are included in this WHO model list of essential medicine, the same list. The first choices are narrow spectrum antibiotics, whereas second choices are broad spectrum antibiotics. Broad spectrum antibiotics because they are acting on a broader group of organisms, so the chances of resistance is also high. So resistance potential is high. So the first choice from access group should be the narrow spectrum agent we should be using. Commonly used antibiotics such as amoxicillin, penicillin, ceftriaxone, proxycillin, these comes in this first line access group antibiotics. Our aim should be use an agent, an antimicrobial agent from this access group if it is first line of treatment or second line of treatment. So we should not be jumping to watch group or to reserve group if the infection etiology is sensitive to access group. Our aim is to encourage use of this access group in vast majority of infections and keep the watch group and reserve group as a reserve category agent.
I think a very important point you have told that in the clinical practice, whether he is a family doctor who is practicing at primary to the tertiary, because you are at the extreme end where the tertiary care center with ICU, and you really feel about the antibiotics selection is very, very important in the clinical setting. I think access group of antibiotics are very important, which commonly Dr. Yash is suggesting all of us is that use access group of antibiotics, which are the 48 which are mentioned in the WHO list. Now, being an antibiotic expert, because I think your one third of patients are having some kind of infection in the ICU settings, selection of antibiotics is also very, very important. Now, while selecting antibiotic as a guidance, if you want to give to family doctors or the physicians, is that what are the 4 5 points which are very important for selection of antibiotics in the clinical practice?
Thanks, Anand. When we are selecting antibiotic, we should be clear about the diagnosis. If the differential includes an infection, our treatment should include an antibiotic. If our differential list is not having a bacterial infection, we should not be using an antibiotic. What happens? We are in a habit of prescribing drugs such as ceftriaxone, amoxicillin, chlorinated, infection or no infection. A patient comes to hospital or patient comes to your clinic, you start writing amoxicillin, clarithromycin or whatever agent. So this habit should go. If there is bacterial infection, you give antibiotic. The second thing you have to look is what are the probable cause of those infections. So when you know the infection, second thing you have to look at the common causes in your area. Suppose you have a febrile patient in your community. The second thing you have to look at is what are the common causes of fever, what are the common patterns. Third thing is you have to look at the sensitivity patterns, especially in last 2 3 years, if not more. I understand that the community physician might not be having an access to the antimicrobial pattern. So what they could do, they could go to the public healthcare facility, they can have their antibiograms. Most of the good microbiology centers are publishing antibiograms for hospitalized as well as for community acquired infections. So they can follow from them, or they can follow the sensitivity pattern from the national guidelines. Then they can only go on to choose the antibiotic. Fourth important thing you have to look at is the toxicity. The drug should be safe for the patient. There should be no common toxicity. Availability should be good. The patient should have a good tolerance and acceptance. You should not be prescribing an antibiotic which the patient is not able to tolerate, or the cost might be prohibitory for some of the patients. So you have to look at many factors. Another important factor you have to look at is the severity of the infection. If the patient has a very severe infection, obviously you have to do the whole battery of tests for the severity of infection, as well as to look at the sensitivity pattern. So these are the common factors which a community physician should be aware.
Yeah, I think these are the most important essential factors for selection of antibiotics. And you are rightly, Dr. Yash has rightly pointed out that differential diagnosis is very important, the severity of the infections, and the antibiotic and the bacterial related issues which are there in the practice. Now, when while discussion was ongoing, we talked about access group of antibiotic and the doxycycline, a drug. I think when we are doing our education at that time in the hospitals, we used to write it heavily, and now again there is a renaissance because of the use of this doxycycline and other different indications. So, if you look at the spectrum, I think it is really broad spectrum kind of a drug. So, what is your thought process in terms of the spectrum of doxycycline?
Thanks for that very important question. See, doxycycline has been a wonderful drug. This is one of those antimicrobials which has withstood the testimony of time. What is the general perception? You launch an antibiotic, resistance will follow. But after 40 years, more than 40 years of launch of doxycycline, we haven't seen resistance commonly, at least for the commonly used indications what we have been using. And the indications for doxycycline has in fact widened in last 40 years. 20 years back, it was used for lesser number of infections, lesser syndromes, infection syndromes, but now we are using it for more and more indications. So we have revisited that doxycycline. The pharmacokinetics, the pharmacodynamics have been a very favorable profile from patient point of view. It has anti-inflammatory properties also. Whenever we talked about antibiotics, we always talked about collateral damage. But when we talk about doxycycline, we talk about collateral benefits. It has a very strong anti-inflammatory action. It has effects on various organisms, gram negative, gram positive, anaerobes, many protozoals, leptospira, rickettsia. So, in cases of community infections like undifferentiated infection, where it could be something like PID or it could be something like rickettsia, it could be a wonder drug. So, if you have to work in a resource limited setting, it could be a wonderful drug. Second, more indication which we see commonly is rickettsia has emerged as a major cause of undifferentiated fever in last 15 years. 2005 onwards, the recognition has increased, the testing has increased, and we have learned how to diagnose various rickettsial infections. And doxycycline has come handy for those infections also. So yes, doxycycline has been revisited, as some other drugs also has been revisited. We have a better understanding of mechanism of action, and we have been using it more and more frequently, not only for community acquired infection but also for hospital acquired infection. I will give you an example. This was year 2008. I was at Max Neurosciences Center, Saket. We had a patient who was airlifted from Canada to India. Patient was in a persistent vegetative state for almost 8 months in Canada, and they have virtually written him off that he is not going to improve neurologically any further. He came to us, we did a battery of tests, but we were also very skeptical whether we are going to change the outcome. And then it turned out to be rickettsial infection. We started doxycycline. After 8 days, patient started improving neurologically. So it is always handy, And we have to always keep in mind there are some infections which could go unnoticed. Why? Because our microbiology is still not that strong. Secondly, cost comes as a factor. We cannot always do a whole battery of tests for all the patients. We have to treat undifferentiated fevers, we have to treat undifferentiated infections, and in such circumstances, doxycycline comes very, very handy. Yeah, doctor. Nice.
Yeah, I think your mentioned right point is that like diabetes is relatively easy to diagnose and manage, or hypertension, but
Yeah.
today the most difficult in the practice is febrile illness because every year there are new differential diagnosis
Yeah,
gets on
absolutely.
adding to the febrile illness. So when the patient has got a febrile illness, he has received antibiotic here and there, the patient has come and there are six, seven differential diagnoses. It's very important that pinpointing the antibiotic is very critical. So, what kind of suggestions you want to give that febrile illness, the doctor can say use doxycycline?
See, I'm not telling that we should be using doxycycline without any different workup for fever. We have to do the workup for fever. But to start with, doxycycline comes as a very, very good choice. I will tell you why. It could be helpful in undifferentiated fever. It could be helpful for various rickettsial infections. It could be helpful for various viral infections. It has shown some activity against dengue. It has shown some activity against herpes simplex, rotavirus, and many other infections like malaria. Also, it has some action. Typhoid also it has some action. Though it is not the drug of choice for typhoid, but we understand the diseases do not happen in black and white. There are gray zones. There could be two infections which are happening simultaneously. If we talk about typhoid, it is very, very common to have two infections simultaneously. So it becomes a good choice if we talk about syndromic approach to fever, especially to undifferentiated fever. So doxycycline becomes a good choice. It could be as a combination therapy with a drug like clarithromycin or amoxicillin carbonate, or if your differentials are more clear and you are precisely thinking about diseases such as leptospirosis or scrub typhus, it could be the sole drug also.
Yeah, I think majority of the diseases we give a polytherapy, like two
Yeah.
antihypertensive drugs, two antidiabetic drugs. I mean, the antibiotics also, I think, to get rid of the infection quicker. Sometimes, as you have mentioned, syndromic management of febrile illness, where there is an undifferentiated factor also. There are two infections also. So here, I think obviously we give two drugs or three drugs to sort out the problem. Your whole practice obviously is majority of the practice is like in sepsis, and there I think if you see and infection and inflammation, there are a lot of sepsis is also there is a lot of underlying inflammation and multi-organ failure which is there. So what is the inflammation component of any infection, especially whether it is a mild, moderate, or severe?
See, there is a saying which goes like, it is not the infection which kills, it is the event which happens after infection. So whether it is a bacterial infection, whether it is COVID, whether it is a dengue, the patient deteriorates because of the immunological cascade, the sepsis cascade, if I call it. The primary etiology, the primary inciting agent might stay, it might decay. So our goal is never microbiological eradication. What we want to cut down the cascade. There is hyperimmune response, which causes organ dysfunction, which causes morbidity, which causes mortality. If we talk about common flu, it is like a mini cytokine storm. If this goes unabated, uncontrolled, it could affect various organs, it could lead to ARDS, it could lead to AKI. So the aim of comprehensive treatment is not only microbiological eradication. Yes, it is important strategy to control the inciting infection, but at the same time, you have to immunomodulate the patient. You have to bring the patient to a lesser degree of immune disturbance. Now, we have talked about immunomodulatory role of various antibiotics. We understand there is no holy grail for treatment of sepsis. There is no magic bullet for sepsis. So we have to act with multimodal strategies. One is antimicrobials, other is organ support, and third is immunomodulation. How can we immunomodulate a patient? Apart from other strategies, early enteral feeding, One is use of various immunomodulatory antimicrobials. If we talk about doxycycline in particular, it has many good immunomodulatory effects. It decreases the level of TNF, it decreases the level of interleukin 6. Interleukin 6 is the master molecule for sepsis. It is the master molecule for dengue also. So it brings down the levels of these cytokines. It also decreases the levels of MMP. MMP will cause severe degree of inflammation in the skin, in the gingiva, in the soft tissue. So decreasing the level of MMP also comes handy in controlling this cytokine storm. Doxycycline also has an action on leaky capillaries. That is why there have been some studies where they have used in dengue also, where the pro-inflammatory cytokine levels came down and the organ dysfunction in dengue patients was less as in the doxycycline group compared to the standard therapy group. So yes, doxycycline has various immunomodulatory effects. Depending on infection, it, it could be helpful. And probably this is one reason why doxycycline crept into critical care also. 10 years back, we never thought we will be using doxycycline in the ICU. But now we have been using it in multi-drug resistant infections. We have been using it in complicated UTI. We have been using it severe dengue as a immunomodulatory strategy. So the uses are widened because of the immunomodulatory property also.
आई थिंक आज एक बहुत ही अच्छा बात जो डॉक्टर यश जवेरी ने अपने को बताया, दैट इज इन्फेक्शन leading to multi-organ damage. So it's like the course of infection is very, very important. And that course is directed not only by the inflammatory load, the infection load, but also by the other components like what is the immunity is working, how the inflammation is playing a role. And I think during the COVID time, everybody has learned about a lot of about inflammation and cytokine storm and everything. So a lot of education, scientific education for across healthcare workers, doctors during this COVID times. But I think this is a very important message as a sepsis expert. You are told that whenever there is an infection, also look for the component of inflammation, immuno, so that the organ damage can be reduced. Because as you have mentioned, even influenza also can cause ARDS if it is not treated or if it is slightly in the severe. I think very important point, clinically very, very relevant point. And as an antibiotic, when there is a doxycycline or azithromycin, this doxycycline has got so much of role on inflammation. In the practice, we don't do this investigation, but I think simply what we do CRP, right? So yeah, first our 20 years back we used to do ESR, and now the ESR is becoming non-specific. We do CRP. So CRP is also an inflammatory marker, but we can't do MMP and IL-6 and all those costlier TNF alpha. But very important is that if there is some elevation of inflammatory markers, is very, very important, and that exactly the point Dr. Yash has told. So this is a very important point about today's one of the discussion. Another important point I want to raise is about resistance, because you deal with so much of tertiary care centers. So the patients are already having antibiotics here and there, and the patient is already the infection burden is because of antibiotics have not worked right in the specific condition. So in your practice, let us say in the last 10 years, how you are seeing the resistance pattern is in the Indian settings or your practice settings?
Yeah. If I say there has been a holocaust of resistance, and there are multiple reasons to it, we cannot probably rectify those reasons, but resistance is always at the back of our mind, whether we have a patient from the community or whether we have a hospital acquired infection. Community acquired infections also, we are seeing a larger degree of resistance. If we talk about quinolones, which are so commonly used, I don't know why people use it, but quinolones, almost 70 to 90% of the antimicrograms will show resistance. Still, people are using it. Not only quinolones will cause worse outcomes because of resistance, but it can also propagate infections, propagate resistance. So we have to avoid using such drugs. We have to use all our antimicrobial stewardship principles very stringently, and we have to act as a steward at all levels, whether we are a community health worker, whether we are in the emergency, or whether we are in the ICU. We have to be very stringent about our choice of antibiotics. We have to follow the basic antimicrobial care bundles always when we decide about infection. We have to decrease the duration, we have to narrow down the therapy as early as possible, we have to send the patient to the right hospital
Yeah, I think doctor is rightly mentioning that the resistance is at the back of the mind while selection of antibiotics in the clinical practice, and especially in the intensive care unit setting, the selection of antibiotics become very very vital, as rightly you are pointing out. So I think you are more elaborating on the resistance. Continue, sir. Yeah.
Okay, so resistance is always on the back of our mind. How can we deal with this? We always talk about the problem, but we never talk about the solutions. The first and foremost solution is look at your antimicrobial patterns. Last 6 months, you cannot follow an antimicrobial pattern from the Western world. They have a different set of infections. They have a different set of they have a different set of infection control strategies. They have a different type of antimicrobials which they have been using. So follow your antimicrobial culture patterns in your unit. Update those antimicrograms every 6 months. Discuss with your peers. Look at novel solutions. And once you have your culture reports, try to de-escalate the antimicrobials. The longer the antimicrobials are used, the higher the chances. What happens? We are very keen to escalate the antibiotics, but we forget to de-escalate. So work as a team and respect every decision. Once you work as a team and every decision in your team is counted, you will be better trained to use these antimicrobials. What we do in our unit, if we have to start antibiotics, we generally discuss in our rounds, 3 or 4 persons, whoever is there. If we have to de-escalate, we discuss in our rounds. What all we can look at while escalating or de-escalating. If your patient is improving, you have to trust your patient. That patient is improving. You cannot be just binding on the idea that I do not want to change the winning horse combination. If the patient is improving, trust it. Look at the physiological pattern, look at the fever trend, look at the patient well-being. If everything is good, obviously the infection load is decreasing. So de-escalate, decrease the number of antibiotics. Once you have the culture sensitivity report, narrow down the drug. If you are using a narrow spectrum agent, the chances of resistance are less. Dr. Abdul.
Yeah, I think a very important point is that escalation as well as de-escalation. And normally we start with two or three antibiotics. I think doxycycline, as you have mentioned in the point, is that a relatively less chance of resistance because of the overall
Absolutely.
usage in the past, and currently it has used in the very very selective and very important indications. So I think one point doctor has rightly mentioned is that even doxycycline is used as an add-on therapy in sepsis, or it is used in other therapies like dengue as well as malaria also in the practice. So that is a very important point you have mentioned. So antibiotic resistance is a point I think every practitioner has to keep in mind. And the not only escalation but de-escalation. It is very important at a specific duration, right? So whether it is a 3 days, whether it is 5 days, whether it is 7 days or 10 days, based upon whatever the condition. And now, normally in the when if the patient has already received 3 or 4 day antibiotics during the discharge, normally how many days you give antibiotics? Obviously, based upon the condition, but still.
See, it depends. It is a very, very difficult question to answer. It depends on the site of infection, how severe was the infection. Three days, and then we review after 3 days.
Yeah.
Yeah.
I think the whole English pattern or the American pattern should not be followed, because, as you are rightly tell, that India-based antibiotic usage and the duration is also based upon the condition and what is the feasibility, how much tolerance is there for the patient. All those factors are also going to create very very important point.
Yeah.
Why?
Another
And
important, yeah, sorry.
yeah, yeah. Go ahead, sir.
Yeah, another important infection which we see more commonly than in the Western world is community-acquired respiratory tract infection. It could be URTI, it could be exacerbation of chronic bronchitis, it could be infective exacerbation of COPD, it could be pneumonia. And if you go on by various guidelines, including the ATS or IDSA 2019 guidelines, if the patient is not very sick or patient does not have comorbidities, then you can use doxycycline alone. If Patient has comorbidities or patient is severely, you can add on a drug depending on your antimicrogram and the resistance pattern in your locality. So we have been using it for various indications: severe pneumonia, severe community acquired pneumonia, hospital acquired pneumonia. Also at times it shows an organism which is sensitive to doxycycline. So we are not using as a monotherapy, but yes, if the antimicrobial pattern shows sensitivity, we are using it as an add-on therapy for hospital-acquired pneumonia also. So the indications, especially for respiratory tract infections, are wide, starting from chronic bronchitis, infective exacerbation, acute exacerbation of COPD, pneumonia, LRTI, URTI, going on to the pediatric population where URTI is very, very common. You cannot all the time do a culture, you cannot do a blood culture. If a poor guy comes with 2000 rupees in his hand, which is the case scenario in vast majority of Indian OPDs, pediatric OPDs. You cannot spend all his 2000 money in investigation. So you have to give a treatment which is affordable and the patient can sustain. And pediatric doxycycline use has been very, very successful, and we have decreased the morbidity and mortality from various pneumonia syndromes in our country with help of doxycycline.
I think Dr. Yash has really told us about what is the exact place of doxycycline in his own practice, as well as the practice which is relevant to each and every Indian doctor across. And one of the beauty of doxycycline is that the broad spectrum, less resistance, the additional anti-inflammatory action, and very smooth pharmacokinetics or dynamic. And one of the point doctor also added is that the accessibility and affordability, which is very, very critical in the Indian practice. Obviously, it may not only even rural, but even in the metro also, the affordability, accessibility is very, very important. So I think today we have got a great sepsis expert and antibiotic expert in this particular field. I think one last message you want to give to all the viewers or the doctors that
Yeah.
about, because you have talked about WHO essential drug, you have talked about access group of antibiotics. So can you give a good message about antibiotic usage in the clinical
Yeah.
practice?
Yeah. When we practice in India, whether it's a community setting or a hospital setting, infection syndrome is always in our back of mind. It could be a trauma patient, it could be a patient with burns. Infection is always in our back of mind. And almost 50% of our ICU patients succumb to various degree of infections. So yes, antimicrobials are mainstay of our treatment. The predicament remains whether we are under treating or over treating. We want to draw a very, very fine balance. We do not want to under treat our patient, and at the same time we do not want to over treat the patient. Yes, we should be justified in whatever we do, so we have to always keep in mind options which are feasible. We always talk about three A's: access, affordability, and acceptability, which we learned from socialistic approach during COVID. So drugs such as doxycycline, which are acceptable, which are affordable, and which are widely available, could come handy, especially for undifferentiated fevers, especially for PIDs, again a big problem, for various respiratory tract infections. So we have to use these drugs very, very judiciously and always remember about immunomodulatory aspects of doxycycline and other agents while you treat infections. Thank you, Dr. Bhatkar.
Thank you very much. I think it's very, very clinical pearls what we got about antibiotic and the infection management in the Indian setting. Thank you, Dr. Yash Zaveri.
Thank you,
I think
Dr. Bhatkar.
antibiotics are the life-saving drugs. Not only they control symptoms, but they also reduce the overall course of the disease. They reduce mortality. They are very, very important in the practice because they improve the quality of life, reduce hospitalization. So all these essential components, and Dr. Yash has given a good message about the antibiotic selection. He talked about antibiotic resistance. He talked about the inflammation component of any infection, and he talked about the antibiotics, especially which is related to doxycycline. Thank you very much. Thanks all the viewers for this KK Agrawal Med Talk Show 491 in collaboration with IGCP, Heart Care Foundation of India, and USV. Enjoy during this particular time. Make your patients happy by selection of a very good antibiotics. Thank you.
Thank you, Doctor. Thank you.